Today I've been given opportunity to talk on pituitary apoplexy. I'll be just discussing few cases. So first of all, pituitary is actually not predisposed for apoplexy. It's a low pressure system and its main supply is from the portal venous blood from the hypothalamus. So it's a low pressure system. Pituitary is not predisposed for apoplexy. Apoplexy happens if there is a tumor, hyperplasia or other predisposing factors because tumor receives direct blood supply, direct arterial blood supply. So 43-year-old lady, severe headache for 1 week, decreased vision for 1 week, no diabetes, no hypertension, no other comorbidities, eumenoric. Prolactin 4.5, cortisol 234, T4 8, sodium potassium within normal limits, started on dexamethasone 6-hourly, some improvement in headache, but progressive decrease in visual acuity from finger counting to perception of light being negative. So this is the scenario where this is the usual thing which we pick up and we just subject the patient to surgery. This is the indication when the patient is being subjected to surgery, and this is the typical case. Nowadays, there is pituitary apoplexy score is also available. If the score is more than equal to 4, then again that becomes an indication for surgery. So this patient was taken up for surgery, necrotic tumor removed, IHC all negative. Here I'd like to highlight that IHC may be negative even in a functional tumor after apoplexy because the tumor is necrotic. So we have to be very careful while evaluating, while saying that IHC is negative. She became hypopit and managed with optimal replacement. Coming to next case, 14-year-old male, severe headache and decreased vision for 11 days, left more than right. Vision improved in 6 to 7 days. So there was no urgent indication for surgery. History of growing fast and being taller than peers for 3 years. So this is a boy with height STS of plus 3.33. MPH adjusted height STS was also high. Arm span was 194. TV was 10 ml bilateral. This is his hormonal profile. So clinically, he appears to have somatotropinoma, but his GH was 2.8. IGF-1 was 231, within normal range, rather low normal. T4 4.2, cortisol 124, testosterone 0.34. So here what I need to highlight is that we need to look at again this profile very carefully and need to look at the relative excess of any hormone. So he is hypothyroid, hypogonad, hypocortisolic. That's why his IGF-1 is not rising. And he has a typical features of having somatotropinoma. He was replaced with T4 and high zone replacement, but of course not testosterone prior to surgery. And his IGF-1 jumped to around 1200. So we should be looking in such cases the relative excess of a particular hormone to diagnose the functionality of tumor. So he had typical apoplexy, operated upon and found to have GH positive tumor. So coming to next case, 35-year-old female, presented with severe headache, no previous comorbidities, T4 normal, prolactin low normal, serum cortisol 110 nanomoles with ACTH of 55, no visual complaints, visual fields and acuity normal, started on dexamethasone, conservatively managed as non-functioning pituitary adenoma, and received hydrocortisone doses in physiological doses. During follow-up, she was picked up to have Cushingoid features. So hydrocortisone replacement was stopped and cortisol repeated. The present cortisol dynamics were ATM cortisol 220. She is typically Cushingoid. ACTH 35, UFC normal. Late night plasma cortisol 345 and 375, ONDST 302, and LDDST 160, clearly non-suppressible ONDST and low-dose dexamethasone suppression test. This was her MRI showing some residual tissue, which we don't know whether it's functional or not. So she underwent M-desmo PET-CT and this picked up the functioning corticotropinoma. She was operated upon, found to have corticotropinoma, ACTH immunostrain positive. Going back to the history, when she had come earlier, her serum cortisol, this 110 was actually after dexamethasone. She was already started on dexamethasone and this was after dexamethasone, so it had come out to be 110. Secondly, even after apoplexy, the patient actually behaves as if the patient has already undergone surgery, and late night plasma cortisol is the thing, or late night salivary cortisol is the thing which is going to rise first. And because these are tumorous corticotrophs, so suppression tests become non-suppressible. ONDST and LDDST is non-suppressible. So apoplexy can lead to partial or complete remission of functional tumor. Clinical and hormone profile should be carefully documented. We need to look for the relative excess of a particular hormone like IGF-1 in the first case and cortisol in the second. And in such cases, even later on, the dynamics of hormone secretion may be atypical, like the one with corticotropinoma, that still AM cortisol was only 220, UFC was normal. Coming to next case, 60-year-old male, sudden onset headache, vision loss in both eyes, drooping of eyelids for last 2 days, hemodynamically stable, conscious, and fully oriented, bilateral absent light perception, complete external ophthalmoplegia, bilateral ptosis, optic atrophy, and gynecomastia. Optic atrophy and gynecomastia suggested a long-standing disease which he was having. He had bilateral ptosis and gynecomastia. Low T4, low LH, low testosterone, cortisol 330, prolactin was 3.01, and he had pancytopenia. HP was 9.8, TLC 1.7, and platelets 23. Bone marrow showed 70% blast cells. So this is the bone marrow picture showing blast cells, and MRI showing typical apoplexy. So what I wanted to highlight from this case is whenever a patient with apoplexy is coming to us, we need to look for any predisposing factor if the patient is having, and this is the list of various predisposing factors which we need to look for if a patient is coming with apoplexy. So this patient actually has come to acinetobacter sepsis in the hospital stay. So coming to imaging in apoplexy, this is a simple diagram which will highlight the different time periods how a blood on MRI behaves. If the patient comes immediately after, within 6 hours, then both T1 and T2 will be iso-intense. Then gradually, this is hypo-intense, iso-intense, and hyper-intense, the same way for T1. So this is very easy to remember. So it's initial iso-intense on both. Then T2 becomes hypo-intense. Then it is T1 hyper-intense and T2 hypo-intense, which is the usual time period when the patient is coming to us at 2 to 7 days. Then both are actually hyper-intense, and then both become, in the chronic phase, both because of the hemosiderin, they become hypo-intense. So this is the way we can pick when probable apoplexy would have happened. So initial 6 hours of apoplexy, we may not find any changes on MRI because it is iso-intense, but this is the CT at that time also shows hyperdense signal, and we can pick up apoplexy. So coming to a typical case where there is hyperintense signal on T1 weighted images, and there is a hypointense surrounding area which suggests again apoplexy. And the surrounding pituitary tissue gets enhanced after giving contrast. This is another case where T1 hyperintensity, and it looks similar to apoplexy. However, what we can see here is that on T2 image, there is a hypointense nodule, which is suggestive of actually Rathke's cyst. So this can be sometimes confusing, but of course, such patients will not typically come with features suggestive of apoplexy. Although very rarely Rathke's cyst also can have apoplexy. So this is another common picture what we see, and that the patient is having solid cystic mass with some hypointense area and some hyperintense area on T1 weighted images, and on T2 again there is hyperintense signal. So this is a typical case of craniopharyngioma, and we can see the calcification on CT. So we can easily differentiate craniopharyngioma from apoplexy. Coming to the next case, 30-year-old man, sudden onset headache, vomiting, and complete loss of vision in the left eye and then right eye for last 10 days, blood pressure within normal limits, complete loss of vision in both eyes with bilateral optic atrophy, neck stiffness and Kernigh's positive. So initially he was thought to have meningoencephalitis. He also had frontal disinhibition syndrome. So lumbar puncture was done prior to coming to us, so it was normal CSF. Sodium was 130, potassium 3.6, T4 low, cortisol 400, testosterone low. This is the CT which is showing a bleed in the pituitary region, and there is infarct in the frontal area. That is the reason for his functional frontal lobe signs. And this is MRI showing apoplexy, and this is angio showing spasm of anterior communicating artery. And he was treated with dexamethasone, and after 2 weeks, this spasm has disappeared. So this spasm of anterior communicating artery led to infarct in this case. So we should be careful about the atypical manifestations of pituitary apoplexy and the differentials, like they can mimic actually meningoencephalitis, but he had optic atrophy, which was suggesting that there is something possibly in the pituitary. This is another case, 42-year-old female, sudden onset loss of vision right side, temporal field loss on the left side, no headache. This lady had come to OPD last week only. And so, although headache is the classical symptom of apoplexy, but sometimes there may not be any headache. So, and it's only loss of vision. She was hypopit, IGF-1 was 62, T4 4.9, cortisol 277, prolactin 10. For her age, LH-FSH were low. So here, what I want to highlight is that we started her on hydrocortisone replacement as well as T4 replacement. So whenever we are starting T4 replacement, as a general thumb rule, we have to first give hydrocortisone and then start T4 replacement. She was started on the replacement, and this is MRI showing pituitary apoplexy. So I have only talked about anterior pituitary hormone deficiencies, but sometimes there can be posterior pituitary also involved in 2 to 20% of the cases, and they can have transient DI also. And rarely there can be inappropriate ADH secretion leading to hyponatremia. So this is the flow, how once the patient is coming to us with apoplexy, we need to give sportive measures, assess fluid and electrolyte balance. We need to do biochemical and endocrine assessment. If there is severely reduced visual acuity, severe and persistent or deteriorating visual field defects, or deteriorating level of consciousness, we have to go for surgical approach. If it is not there, we can manage the patient conservatively. If the patient is stable or improving, then we can continue with conservative management. If no, we again need to consider surgery. So there are certain controversies in the management. So early surgery, that is within 3 to 7 days versus beyond 7 days, has shown comparable results. Conservative approach versus surgery again has shown comparable result. But there is a problem here that there was selection bias. The patients who were having severe deficits or altered sensorium were actually taken up for surgery. So there was lack of appropriate matched patients. So indirectly it means that we are choosing right patient for surgery and right patient for conservative management. So severe deficits, altered sensorium, bigger tumors need to be operated upon. There is another study which suggests that if there is a single large hypodense area within the tumor, then tumor resolutes. So they can also be called for conservative management. If there are mild deficits suspected to have prolactinoma and low pituitary apoplexy score, we can easily go for conservative management and monitor the patient. So we need to carefully monitor fluid and electrolyte balance, replacement of deficient hormones, especially corticosteroids. Look for relative excess. The word here is relative excess of any hormone or clinical features of functional tumor. Early pituitary surgery is reserved for deteriorating visual defects or altered sensorium, and long-term monitoring for pituitary function or recurrence of pituitary tumor is warranted. Thank you.